Okay, I think we will go ahead and get started. Thanks everyone for introducing yourselves. Welcome, welcome. I'm so glad you could join. Um, we have an interprofessional crew, which is the way we like it. That's the best way to provide excellent care for older adults is as teams. Um, I'm Kate Bennett. Welcome to Project Echo Geriatrics. If this is your first time attending, welcome, welcome. And if you are returning, welcome also. Glad to see you back. I see many familiar names and faces, so thanks for joining. I'm Kate Bennett. I'm the medical director for Project Echo, and I am a geriatrician based at Harborview. And I will be doing our traditional kickoff. We were supposed to kick off last month, but it seemed that technology around the world wasn't working and a bunch of people couldn't even turn on their computers because it's a huge cyber outage. So we just canceled. We have done that so very rarely. This project has been, these sessions have been running monthly since January of 2016. Some of you have been there for many of those sessions. It is very rare for us to cancel, so that was a hopefully once in a long time experience. But thanks for your patience, and we'll just get kicked off this month. It got everyone a chance. It gave everyone a chance to settle into the new academic year. So welcome to those of you who are in new roles as of July or recently. I'll go ahead and get started. If you have trouble, Zoom has done some interesting things to my audio lately. So if you have trouble hearing me, it is not your speakers, just chat it in and let me know and I will do something different. Are you all able to hear me okay right now? Awesome, I see heads nodding, thank you. All right, so I'll go ahead and get started, but if you haven't already introduced yourself in the chat, please do. Are you able to see my slides okay? Awesome, okay. So what we're gonna do, I'm going to give you a quick intro to Project Echo in general and why we're doing this, and talk some about age-friendly care. And for some of you who've been joining us for a while, some of this you've heard before, but it's always good to repeat important messages and refresh them a little bit. So I'll talk about the context of Project Echo Geriatrics, why we're doing this and what it is. Talk about age-friendly healthcare, which is a growing movement and rapidly evolving. And then we'll just talk about some of the nuts and bolts of Echo participation for those of you who are new. So what is Echo? Echo stands for the Extension for Community Healthcare Outcomes. Project Echo was started by a doctor by the name of Sanjeev Arora in New Mexico. He is a liver disease specialist, and he had this problem where he had 30,000 patients who needed to be seen in specialty care for treatment of hepatitis C, and they had a 6-month wait to see the specialists at the one academic medical center in New Mexico. And so he thought, what if I trained primary care providers and teams in primary care settings to provide the specialty care? Let's try that. So he used Zoom before Zoom was even cool. We all use Zoom now, but back then, not as many people were using it. And via Zoom, he had these regular sessions where he would do a short didactic and then talk about patients with hepatitis C that were being cared for in the primary care clinics and provide mentorship and guidance to these teams and particularly primary care providers who are providing the care. And what they found was that the care provided by the trained primary care providers with this ECHO program was just as good as when folks traveled all the way to the specialty center. And then he was able to reduce his wait lists and expand the capacity for care. And also they were able to reach people who otherwise were not receiving medical care for their hepatitis C and people were more confident in the person who was providing the care to them. So it was great. And so it launched this ECHO movement where Project ECHO has been used over the last decade or so to train people in a lot of different areas where specialized knowledge is needed, but to really train primary care providers, teams of interprofessional care providers in various settings to really be able to provide more equitable care wherever someone is. So ECHO has been used for hepatitis C and HIV and palliative care and geriatrics and anything you can imagine. It's even been used in K through 12 education. So this model has been rapidly disseminated for lots of uses and has shown over and over that it's a really effective way to improve the care of folks more broadly. And at this point, over 6 million ECHO session attendances have happened. It's just exploded, particularly during the pandemic, and continues to be an evidence-based model to disseminate specialty knowledge. So why are we doing it for geriatrics? It's no secret that the number of older adults in this country and throughout the world is growing over time, and it's growing really rapidly. And so we're all caring for a lot of older adults wherever we may practice and whatever our profession is. But as an example, in medicine, geriatric medicine, the specialty includes only about 7,000 geriatricians. So I and all of my colleagues, we can't take care of all the older adults. We really all need to know how to provide high quality care for older adults. So Project ECHO is a way to disseminate best practices to everyone so that no matter where someone enters the healthcare system, no matter where they're receiving care, that they're all receiving high quality, evidence-based care. So Project ECHO Geriatrics launched in January of 2016 as part of our Northwest Geriatrics Workforce Enhancement Center. We've run sessions year-round every month. They always run an hour, 12:30 to 1:30 on the third Friday of the month. We start off with a short didactic that's 15 minutes on a very focused topic. And then we have some time for discussion. And then the most important part of ECHO is discussing real patients, real people that you are interacting with, where there might be challenges to providing the best care or questions about how to provide the best care. And that's how we learn all together. So I'll just give an example to kick off my discussion of what age-friendly care is, to give an example of what age-friendly care isn't, and unfortunately is very prevalent. So this is based on a real person that I met with just some minor things changed. So I met this 90-year-old woman who had 8 years of progressive forgetfulness and well-controlled hypertension and some diabetes. She lives with her daughter. She loves to tell stories about raising her kids and repeats herself often, and needs a lot of help with her activities of daily living, such as, medications and keeping track of appointments, because she's no longer able to keep track of that. And she needs some reminders of which types of clothes to wear for which types of weather. She walks with a walker, but recently started falling and needing assistance walking. So she gets admitted to the hospital with cellulitis, which should be a pretty straightforward admission. She wasn't mobilized during her stay and she developed delirium. She was given a benzodiazepine for anxiety, which ended up making her delirium even worse. The team planned for a nursing home discharge, but it turned out that the family felt very strongly about nursing homes and didn't want her to go to one. And she ended up discharging home after they had done a bunch of arranging. She had no advance directives, no durable power of attorney, and she ended up being discharged home. And there she was bedbound. She was newly not able to speak, and she had ongoing delirium. She ended up developing pressure ulcers and further weight loss, and ended up having a cardiac arrest just a week after discharge and dying in the emergency room. This is not age-friendly care, but unfortunately is the type of care that's kind of prevalent, that is prevalent in our country and needs to change. So, over a lot of the things you saw in this case are really common. Over 30% of older adults are prescribed medications that are potentially inappropriate, that might contribute to cognitive impairment or delirium or falls. Falls result in over 2.8 million injuries treated in emergency rooms annually. and lead to over 800,000 hospitalizations, even though we know there are preventive strategies for falls. Only about half of people with dementia are actually diagnosed with it. This woman sounds like she has dementia, but she doesn't have a diagnosis and hasn't had an evaluation. And this all happens even though older adults spend a lot of time interacting with the healthcare system. On average, they spend 17 contact days per year engaged in healthcare, whether that's a clinic visit or a therapy visit or going to a lab or having a procedure. So it's not the quantity of care, it's the quality, it's the care that people are receiving. So because of this, and because of the growing older adult population, the Institute for Healthcare Improvement partnered with several other entities, the John A. Hartford Foundation, which does a lot of care improvement for older adults, American Hospital Association, Catholic Health Association of the United States, and said, we need to change things and we need to do it quickly. So they launched this age-friendly healthcare movement. So what is age-friendly healthcare? It's a healthcare that follows an essential set of evidence-based practices, which are the 4 M's, and I'll talk about those in a moment. It causes no harm, and it aligns with what matters to the older adult and their family caregivers. How they got to the essential set of evidence-based practices is by looking at the literature and seeing what models of care are out there for older adults, things that prevent delirium, prevent falls, improve care for people with dementia, and what do they have common across all of them. And they distilled it down and distilled it down. And through this group of experts and looking at the evidence, they distilled it down to these 4 M's of age-friendly care that should be reliably assessed and acted upon for each older adult. And the 4 M's are what matters. And this isn't just about advanced care planning. This is about what is most important to someone, knowing that. Do they want to volunteer? Do they want to walk their dog? Do they want to spend time with family? So assessing that for everyone you interact with and making sure you're lining up the care with what's most important to someone. Medication is trying to avoid high-risk medications, knowing what the medications even are, and then doing something about it if you're finding medications that might be causing interference with mobility or mentation, for example. Mentation is thinking about delirium, depression, dementia, cognitive impairment across settings of care, making sure you're assessing for those and acting upon them when you find them. And mobility is really talking about fall prevention, but really making sure that people are moving safely every day to do what matters to them. And it also is including functional status, how someone's doing with their activities of daily living. So every older adult should reliably receive all of these 4 M's assessed and acted upon, no matter where they enter the healthcare system. And I wrote out, and I'll share the slides with everyone afterward, some of the details of the 4 M's, but I already told you, so I won't read the slide to you. There are some key points to how age-friendly care is envisioned by the Institute for Healthcare Improvement as they rolled this out. These are a framework. So when I see an older adult, I'm always thinking, have I assessed and acted upon all the 4 M's? I'm thinking about it for everyone I'm taking care of. So it's a framework, just a lens through which you view care. And it's meant that you do all of them and that every older adult receives them. And it can be implemented across entire health systems, or you could just do it yourself. So however it's done, it's still age-friendly care, whether an entire hospital is doing it or you are doing it in an individual visit. It should be incorporated in what you're already doing. It shouldn't be, I'm going to do my visit, I'm going to talk to this patient, and then I'm going to do this 4 M's thing. It should be just integrated seamlessly into what you're doing. It also means that you don't have to use any particular tool. There's not like this package of things you have to use to assess and act upon age-friendly care. As long as you're using something that works in your setting for you, is based in evidence and can be done consistently, that counts. So there's a lot of flexibility in how age-friendly care is rolled out. There are so many participating sites now. They started this in 2017 with 5 pioneering healthcare systems, and now it's up to over 6,000 hospitals and practices who have told IHI by officially signing up that they are providing age-friendly care. And it really isn't that difficult to, if you're doing this work, to get the age-friendly recognition. It's making sure you're assessing and acting upon the 4Ms and describing that. And then you fill out a survey and submit it to IHI, and it's free. And they have a lot of tools for areas where you find that you or your healthcare system or your clinic aren't quite meeting this, to help you implement it, and things you can integrate into the EHR, different tools you can use for the different assessments you need to do. And again, for all of these, you need to assess and act upon each of the 4Ms. It doesn't help you to know that someone is at risk for falling if you're not going to do something about it. It doesn't help you to know that someone has cognitive impairment if you're not going to make a plan afterward. So it can't just be screening or collecting the information. It has to be a holistic plan. There, like I mentioned, IHI has a bunch of guides for how to do this and examples. So you can look at this for yourself or for your health system if you haven't already. So what if this same person that I described before received age-friendly care instead of the care that she did receive? So we have this 90-year-old woman, again, reminding you that she has hypertension, but now she's followed in a health system that implements the 4M. So in the original case, she developed delirium, she had undiagnosed probable dementia, she was falling, and she ended up dying shortly after the hospital with care that really didn't take into consideration what was important to her. So what if it was age-friendly care? So it's both outpatient and inpatient here. So outpatient, her mentation was assessed. She ended up with an abnormal cognitive screen many years ago and was diagnosed with Alzheimer's disease. And because it was diagnosed early, she was able to designate a healthcare proxy and have a deep discussion with her healthcare team about what's important to her, which is time with her family. She had been screened for falls and found that she was at increased risk for falls, so was referred to exercise programs and educated on home safety. Her high-risk medications were deprescribed, things that might have been contributing to cognitive impairment and falls. And then when she was admitted to the hospital for that skin infection, they reviewed what matters to her and confirmed it with her daughter, which was being at home with her family. And for her mentation, they screened her for delirium. She ended up developing delirium because she was at risk, but it was mild because they had protocols in place, and they kept her mobilized, and they made sure they avoided high-risk medications. And they kept her moving in the hospital so that when she discharged, instead of being bedbound, she needed a walker after the hospital stay. And she returned home with the support of her daughter and home health, which is where she wanted to be. And then as her dementia reached its final stages, her daughter enrolled her in hospice, and she was able to spend her last days at home with her family. So that's a much better ending to the story. And this is the care that everyone deserves. The Center for Medicare and Medicare Services is paying a lot of attention to this, and very hot off the presses is that all hospitals who report quality metrics to Center for Medicare and Medicaid Services, most hospitals in the United States, have to attest that they are providing age-friendly care. And they have to start doing this as of 2025. And as of 2027, it will impact their payment. Also starting in 2025, hospitals on Medicare's Care Compare website will have it reported whether or not they're providing age-friendly care. So there's a big push. It's affecting public reporting and finances. And so there's a big push to do this very quickly. And you can see that the momentum's been building. So like I said, this is an exciting time in the care of older adults, and you'll hear more about this. And this isn't the last of it. You're going to see more and more of it. So I'm going to step away from talking about age-friendly care for a second. The way we teach about age-friendly care and talk about it and support each other through it is through this Project ECHO program. So that, and we have a interprofessional team. This is about a 5-year-old photo at this point, with some of our early on panel members. And it's evolved over time, but the panel, although the folks on it change, the disciplines are always the same because geriatrics is an interprofessional it has to be interprofessional. Taking care of older adults has to be interprofessional. Like I said, Project Echo at its heart has cases, and I invite any of you to present a case at a future session. We always send out a case form in advance. We like to focus on primary care, because if we can do things upstream and make care more age-friendly, then we can make a big difference across the healthcare system. And for all of you, you have experiences in primary care settings that you might come across challenging scenarios. Anyone can present from your team. You could be a student, you could be a faculty member, you could be a resident, you could be any health profession at all. And we've had a variety of folks present, and anyone from your team can present, and multiple people from your team can present. It's okay to leave sections on our case forms blank. You don't have to provide it. It's just a guide to some of the key information you might want to gather and need in order to share your case, but you don't have to fill out every detail. Don't let that be a barrier. We have folks submit it 48 hours in advance if you can. And we ask that for those of you participating at residency program sites, that at least one case from your site is presented sometime between July and June. Now we're at August through June. It just helps us understand each other's healthcare system, and presenting a case gives you a different kind of learning. So I encourage you to do that. Amy Farrell is our fantastic program coordinator for ECHO and our project manager for the Northwest Geriatric Workforce Enhancement Center. And she sends out the case form and will be the key person you'll be communicating with if you're going to submit a case. We always send out resource emails after the session, usually along with the reminder email. So there will be follow-up information, and make sure you're on our ECHO listserv if you're not already, so that you can get that information and follow up. Just a few other nuts and bolts as I wrap up. I encourage you to have your video on. It's good for community building. I know sometimes you can't, so that's perfectly fine. But if you can, it does really help us get to know each other as a community of learning, and sharing best practices. Invite your team. It's good to have teams of folks, physical therapists, occupational therapists, social workers, nurses, certified nursing assistants, whoever you work with on your team. And a lot of you have a variety of members of your team, and I won't list every single one of them, but just be welcoming to everyone on your team, because it is so important for our discussions and for all of our learning and care. And this is all Teach, All Learn. I learn a ton from you. So please do speak up and share, especially during the case discussion, but also as we're discussing topics that come up in the didactics. All the didactics are recorded and are on our website, so you can always access those afterward, but we do not record the case discussions to keep everything HIPAA compliant. So let's make healthcare more age-friendly. It's the right thing to do, and we're all moving toward it already. So let's do it. And I look forward to spending time with all of you on this session and in future sessions.